Chronic obstructive pulmonary disease. Let's make it simple and easy for you guys to understand for your nursing classes and the NCLEX. Hey guys, my name is Will Kirkpatrick. I'm a nursing educator inside the Coursera platform, and today we're going to go over chronic obstructive pulmonary disease, or in other words, COPD. In this video, we're going to describe COPD with their pathophysiology, the signs and symptoms, risk factors and complications, the medical treatment, and the nursing interventions associated. If you're watching this video, you're probably preparing for your pulmonary exam in nursing school. If you guys are needing further support, make sure you guys contact us on tactilevr.com to contact your nursing educator directly. So let's start with pathophysiology. What is COPD? It is chronic obstructive pulmonary disease, or you could just simply say it's airflow limitation that is irreversible. Now, there are two subcategories of COPD. There is chronic bronchitis and there is emphysema. You will need to know this for your nursing exams and NCLEX, so make sure you guys write all this stuff down. Let's start with chronic bronchitis. So chronic bronchitis, if you think of someone just getting bronchitis, right? It's kind of deep in the lungs, there's a lot of mucus. Well, COPD, it's really no different, but this time it's irreversible and it's chronic. So it lasts a long period of time, and it's never going away for these patients. So chronic bronchitis is the hypertrophy of those bronchial glands in the bronchial walls. We have something called goblet cells in our airway that produce mucus to protect the airway from damage. Well, when there's constant irritation in that bronchial wall, it's going to irritate those goblet cells, and those goblet cells are going to produce lots of mucus. With the irritation, you're going to expect inflammation, mucus, and then from that inflammation, you're going to have chronic edema inside that airway. And then we also have something called cilia in our airways. And what is the function of cilia? It propels bacteria away from the lungs, so it goes back up into our upper respiratory tract to keep it away from our alveoli. So what does this triad of issues do inside chronic bronchitis? Well, we have inflammation, and then we have mucus production, and then we have edema. What does that do to the airway? It narrows the airway. What does a narrow airway cause? Well, we're going to have difficulty inhaling oxygen and getting it to the alveoli to do its thing with gas exchange. So the thing with chronic bronchitis, the air just simply can't get through to reach those alveolar sacs because it's narrow. So we have a low ventilation issue with our lungs. Now, thankfully, guys, if you understand that, then we're going to go to the complete opposite, which is emphysema. Emphysema is pretty much the opposite in pathophysiology, but it causes the same thing, obstructive airway. Now, we talked about how chronic bronchitis is a narrow airway. Well, emphysema, it's a distended and flimsy airway. So what I want you to remember, to help you remember this, emphysema means enlargement. Emphysema is the enlargement of the airways. Not only are the airways enlarged, they're also very flimsy and weak. So what does that do to the actual surface area of the alveoli? Well, when the surface area is decreased because it's so flimsy and weak, it can collapse. And when that collapses, there's no room for gas exchange. So what happens when we don't get the proper oxygenation to our alveolar sacs? Well, there's a destruction of those alveoli. Then what else does a flimsy airway do? Well, of course, it decreases the airflow in, but here's another thing. It decreases the airflow out as well. Now, with emphysema, the NCLEX and your nursing exams love to use key terms. So make sure you guys write these down. They like to use air trapping. What does air trapping mean? Well, like we said, when we breathe in air, the volume gets into our lungs, right? We expand the lungs. And then on the way out, because those walls are so flimsy, they're kind of collapsed, they can't really exhale the amount of volume that they'd like to exhale, so the air literally gets trapped in the lungs. So that is a key term they like to use. And then they also like to use the words increased compliance. What is compliance? It's flimsiness, so it's increased flimsiness. And then lastly, they like to use the terms decreased elasticity. What is elastic? You think of a rubber band where you pull it and then it comes back. That's exactly what the lungs and emphysema do not do. We pull them open, and then they don't go back because it's air trapping. They get stuck. So because the walls are so flimsy, they're not contracting back like they should. So it's decreased elasticity. So guys, remember those. Air trapping, decreased elasticity, increased compliance. You're going to see it on your exam. If you guys understand that pathophysiology, you're going to easily understand the signs and symptoms, because the signs and symptoms commonly get questioned about on the differences between chronic bronchitis and emphysema. So let's start again with chronic bronchitis. Now, a lot of times, you might have already heard this, that chronic bronchitis is referred to as blue bloaters, which I think is a good description. And let's go back to the pathophysiology and reflect it on the signs and symptoms. So first of all, blue, what does that really mean? Well, that means cyanosis. So cyanosis is common with chronic bronchitis because remember, what did we talk about? It's a narrow airway, which limits the airflow to come in. What do we rely on for airflow to come in? Well, that airflow coming in has oxygen. So when we have a decreased airflow coming into the lungs, then we have a decreased amount of oxygen reaching those alveoli sacs. So that is why these patients are blue. So why do we even call them blue bloaters? So what's the bloaters thing all about? So the bloaters has to do with the inflammation and edema in that airway. What does that do? Well, it narrows the airway, of course, and that increases the pressure in the lungs. What happens when there's increased pressure in the lungs? Well, we have something called the right ventricle that puts unoxygenated blood into the lungs to gather more oxygen and get rid of that CO2. Well, the perfusion that gets to that lungs is now having meeting resistance with the increased pressure in that lungs. So when we have increased pressure in that lung, that's going to back up and put more resistance on that pulmonary artery, and that pulmonary artery is going to get stressed out, and that's going to put stress on the right ventricle, where then you have something called right-sided heart failure. A fancy term they like to use is cor pulmonale. And what does right-sided heart failure cause? You may or may not know yet, but right-sided heart failure causes a backup of blood into the body. So think R, right-sided heart failure, rest of body. So the blood gets backed up into the body, and then what does that cause? That causes peripheral edema. So then we have a bloated patient. All right, so quick little recap with the chronic bronchitis. We call them blue bloaters because blue equals cyanosis. Cyanosis is caused by the decreased amount of oxygen that can get through those narrowed airways in the bronchioles to the alveoli, so we have a decreased amount of oxygen intake. And we call them bloaters because that pressure increases in that lung because of the inflammation and the edema that then backs up into the right side of the heart, which causes right-sided heart failure, which relates to the bloating because there's peripheral edema. Now, emphysema, we like to call these patients pink puffers. So why do we call them pink puffers? Well, first of all, we call them pink because they don't necessarily have an oxygenation issue like chronic bronchitis. Because remember, emphysema is not a narrowed airway, it's a flimsy, weak, distended airway, or an enlarged airway. Remember emphysema, E, enlargement, E. So that is your emphysema. So some common signs and symptoms they like to put on your test is one, barrel chest. Barrel chest is associated with emphysema because of why? Because of air trapping. Remember we talked about how the air cannot get out because the lungs have decreased elasticity. They can't recoil back. Hey guys, it's Wilker Patrick, nursing educator inside Coursera. I wanted to let you guys know that I will help you with anything you need at any time if you just send me a text at 940-218-4062, 940-218-4062. Let's get back to the video. Because we have a recoiling in our lungs that helps push the air out to get rid of that CO2. But when we have a decreased elasticity because the lungs can't get rid of that CO2, the lungs get trapped. And then that entrapment of air, of course, distends our thoracic cavity, which causes a barrel chest. And this directly relates to why we call them puffers. So what would you think would happen if you can't get rid of all the air? It causes a lot of issues, right? Where you can't do any deep breathing. When you have air already in your lungs and the next time you inhale, there's already air in your lungs, you really can't do a deep breath because your lungs are already distended. So these patients puff. They do really short, quick little breaths because they can't take full breaths because there's air stuck in their lungs. So because of that air being stuck in their lungs, they can't really get volume in or out. So they're breathing super rapidly. And what does that rapid breathing do you think would cause? It would cause weight loss because they're working super hard. Just them breathing, they're burning a lot of calories. So a lot of the times these patients are going to be skinny and malnourished looking versus those chronic bronchitis patients who are bloated because they're fluid overloaded. And then another key term they like to use with emphysema signs and symptoms is Hoover sign. So this is inspiratory retraction. So when they breathe in, it goes the opposite way of what you would think. So the chest cavity is doing that because once again, the air is distended in the lungs and it's not allowing your chest cavity to fully expand. So this is sort of a compensation that our thoracic cavity tries to do. So don't forget, Hoover sign is associated with the emphysema. Now we have also general signs and symptoms that are associated with both chronic bronchitis and emphysema, which is your cough and your dyspnea. So shortness of breath, you're going to see that with both of them. You're going to hear some adventitious lung sounds with both, whether it's rhonchi or rales. I will say rhonchi is most likely going to be associated with your chronic bronchitis because of the mucus in those bronchioles. Remember, rhonchi is in the bronchi. Both are associated with clubbing. That's another sign and symptom they love to ask about on nursing exams and the NCLEX. Clubbing is there because of the chronic deficiency in oxygen. So that's another thing that our body just naturally does when we are low in oxygen for a long period of time. Both of these types of COPD will also have decreased chest excursion. So once again, they're going to have a decreased expansion of that thoracic cavity because of the inability to intake air or the inability to exhale the air. And then lastly, they're more likely to both get frequent lung infections. All right, let's talk about risk factors. So risk factors of COPD, everyone knows that smoking is associated with COPD. Because of the chronic damage to those bronchial walls, smoking is very toxic to the lung tissue, so it eventually causes lung disease such as COPD. Now, other risk factors is occupational exposure, so you have a job that exposes you to air pollutants. Also, patients who have had a long history of asthma are more likely to have COPD. And then lastly, guys, write this down. Emphysema is specifically associated with something called an antiprotease deficiency. Now, they don't know everything about this, but this is considered a genetic cause. All right, so complications. Well, the worst of the worst is respiratory failure. So when we talk about how these patients have frequent lung infections, well, those complications is a lot of the times pneumonia. So we call this COPD exacerbation. And then what that pneumonia can do is cause something called respiratory failure, which is where we start having these critical care patients who need much more aggressive oxygenation or ventilation care. Now, we talked about this in our signs and symptoms, and it commonly gets asked about in your nursing exams and the NCLEX. So why is chronic bronchitis called blue bloaters? Once again, because it can cause right-sided heart failure. So that's another complication that commonly gets tested about. And because the heart gets stressed out in that case, there's also a chance for arrhythmias. And because the lung tissue is damaged in a way, you're also at more risk for pneumothorax. So that's another complication. All right, moving right on to diagnostics. So what do we use to diagnose COPD? The hallmark test for COPD is a pulmonary function test. Now write that down. Now specifically the pulmonary function test, there is something called the forced expiratory volume with the ratio of the forced vital capacity. Now if that ratio is below 70% and the duration has been more than 6 months, then that would indicate a COPD diagnosis. Now as you guys know, nurses won't be involved with the COPD diagnosis, but what do we need to monitor when they're in the hospital? Well, what we typically monitor is arterial blood gases to monitor the status of their respiratory function. What are COPD patients at risk for? Well, if they can't get rid of CO2, that causes acidosis, and specifically respiratory acidosis. But of course, in the hospital setting, we're going to be monitoring lots and lots of different labs, such as their CBC, and of course their electrolyte panel to monitor that as well. Now, interventions. Now, I want to tell you something that's very simple to understand. These nursing exams and the NCLEX love to question you about one specific thing, is that these patients, it is chronic obstructive pulmonary disease. What is it obstructing? It's obstructing ventilation, so the movement of air into your lungs. So the most therapeutic intervention we can do is improve ventilation, not necessarily improving oxygenation. So why I say that and start with that is because a lot of these nursing exams in the NCLEX, they love to ask you if you want to go up on that oxygen if your patient's having issues with new onset difficulty breathing. But the thing is, with these COPD patients, we want to be very careful on increasing that oxygen because what it can do is cause even worse respiratory depression. To put it simple, healthy people like you and I who have healthy lungs, is that when we have a decreased amount of oxygen in our blood, our bodies compensate by increasing the respiration rate because that's just what our healthy lungs do. But when there is an unhealthy patient with chronic obstructive pulmonary disease where they've had low oxygen levels in their blood for a long period of time, what do you think happens when you suddenly increase the oxygen levels in their blood? Oh, it's time to relax. Okay, so my lungs are actually doing good now. The oxygen in my blood is at a good level. It's higher than it's ever been before. Now I can just relax. So this is pretty much communicating to them that they can decrease the ventilation. What's the number one issue with these patients? It's the ventilation of the lungs. So when they have an answer option like this on your nursing exams, 99.999% of the time, it is not going to be correct if there's an answer option that says increase the oxygen rate 4 to 8 liters per minute. We want to give these patients oxygen with caution. Typically, we like to keep it 1 to 2 liters per minute, or at least the baseline. If they use oxygen at home and they come into the hospital, we want to keep them as close to their baseline as possible. All right, so we talked about how ventilation is the number one issue. Well, what can nurses do to help improve the ventilation? Number one, incentive spirometry. So we encourage their ability to exercise the lungs. So incentive spirometry is that device in the hospital setting that you put at your patient's bedside. And what it does, it allows your patient to inhale and really expand those lungs up, open up those alveolar sacs to improve the ventilation that gets there. So by opening up those alveolar sacs, it's improving the oxygen delivery and the CO2 removal. So incentive spirometry is typically done 10 times every hour while awake. We can also do coughing and deep breathing, which is always encouraged with COPD patients because coughing helps expel that mucus, which narrows the airway. And of course, deep breathing, once again, expands those alveoli, so it improves the ventilation. Now, there are also other things such as chest physiotherapy, but that's not typically associated with COPD patients, but only in severe cases, and especially if they have a neurological deficit with their diaphragm, it's more commonly used. But with patients with cystic fibrosis, for example, that would be more common. But specifically with chest physiotherapy, it's much more used when they have a high amount of secretion. So if it is a COPD patient with high amounts of secretions, then you might see it with them. And also educating our patients on diaphragmatic breathing also helps expand those lungs once again. So let's talk diet. So with COPD patients specifically, we want to encourage small, frequent meals with high protein. Make sure you guys write that down. The nursing exams and the NCLEX love asking about that. And if they don't have a cardiac issue such as heart failure, then we want to increase the hydration, because what does increasing hydration do? It thins out that mucus, which when we thin out the mucus, it makes it more easy to get rid of it out of our lungs. So when we do coughing and deep breathing, we're more likely to expel that mucus out. And then it also opens up the airways in return. Now let's talk medications. So the common medications that you'll see in the hospital setting with a COPD patient is, of course, bronchodilators and corticosteroids. So first, starting with bronchodilators, they do exactly what they say to do. They dilate the bronchi. So as you guys know, the issue is that we don't have enough ventilation. So by opening up the bronchi, it allows air to come in and out, and it increases the ventilation. Now there is one thing that the nursing exams and the NCLEX try to trick you on with bronchodilators specifically. The thing you have to do with caution with bronchodilators is that you have to know that it increases your heart rate and it increases your blood pressure. Why? Because it's a beta agonist, which means it triggers the beta stimulation. So when we talk about beta blockers, right, where that slows down the heart, it reduces your chronotropic with your heart. Well, with beta agonists, it stimulates that. So it increases your heart rate, it increases your blood pressure. So if there's a patient specifically who is at high risk for a stroke, or if they've had a stroke, then a lot of the times bronchodilators kind of like to be avoided. So make sure you guys write that down. Bronchodilators, they're great for the lungs, but we have to be cautious with the heart. The common suffix with bronchodilators is your terol, so albuterol or salmeterol are common bronchodilators that you'll see. And then moving on to corticosteroids. So corticosteroids work by reducing the inflammation in the lungs and, of course, throughout the entire body. But we give these to COPD patients to reduce that inflammation, and once again, that helps open up the airways to improve ventilation. But once again, there is also another caution that you need to know for your nursing exams and the NCLEX is that corticosteroids increases the level of cortisol, and cortisol increases the level of blood glucose. And what loves glucose? Bacteria loves glucose. So if it's a patient with really bad pneumonia, then a lot of the times they like to avoid giving corticosteroids, especially if they're concerned about the infection getting worse. So the common suffix with corticosteroids is inide, asone, or alone. All right, guys, so let's lastly talk about those specific nursing interventions that you would do at the bedside to improve ventilation, because the number one goal for these COPD patients is to improve their ventilation. We talked about it a little bit with the treatment is incentive spirometry, coughing and deep breathing, pursed lip breathing and diaphragmatic breathing, where it helps expand the lungs and slow down their breathing, chest physiotherapy if prescribed, and make sure you guys write this down, semi-Fowler's or Fowler's position. We want to encourage a diet that is small and frequent meals with high amounts of protein, and number one, guys, make sure to be careful with oxygen supplementation. There's very rarely a case where you go super high with the oxygen really quickly with a COPD patient, because you can make it much worse. All right, guys, I hope that helped you guys understand COPD with all the different concepts that you'll be asked about with your pulmonary nursing exam. Once again, guys, if you're having trouble understanding certain concepts, we invite you to come contact one of our nursing educators on tactilevr.com or send us a text to 940-218-4062. Thank you guys so much for watching. We'll see you in the next video. Hey guys, first of all, thank you so much for watching the video entirely through. It makes our day if we know that nursing school got a little bit easier after watching one of our videos. If you guys like this video, make sure you like it, subscribe to the channel for more, and drop down in the comments for any more ideas that you need help with nursing school. If you want to contact me personally, it's 940-218-4062. Thank you guys for watching. We'll see you in the next video.